Hello, my name is Nichola Gale. I'm a senior lecturer at Cardiff University, and I would like to present some of the work I've been undertaking, which was funded by the Research Capacity Building Collaboration Wales as a postdoctoral fellowship. The study was called the co-production of a structured home-based physical activity programme for people with lung cancer and established weight loss. And I've been working with Professor Jane Hopkinson at Cardiff University, Dr. David Wasley at Cardiff Metropolitan University, and Dr. Anthony Byrne at Cardiff and Vale Health Board. So by way of background, we know that cancer is a leading cause of death and disability in Wales. And lung cancer is quite prevalent, with 2,400 new lung cancer cases each year. Patients with lung cancer do quite badly. Generally, they have a poorer prognosis, and approximately 60% present as the picture shows, with significant weight loss. And as you can imagine, this has a significant impact on their muscle, bulk and capacity. It results in reduced physical activity, reduced function and reduced well-being. As a consequence, there's increased burden on carers and increased cost to health and social care as people lose their independence. There's some evidence that physical activity can reduce disease burden in a number of conditions, including other cancers, but in patients with lung cancer and weight loss, there's limited evidence. The studies that have been undertaken have been short-term high-intensity exercise programs, and have really suffered from high dropout and poor adherence, which may be because sort of high intensity exercise is not suitable for these kind of patients with weight loss. So there's a need to design new interventions which are acceptable and sustainable in such patients. So my aim was to use co-production, which is an approach which involves professionals and service users working in equal partnership to develop healthcare services, and it's seen as a more effective agent of change. And it's seen to increase more sustainable outcomes. So my methods are shown briefly. So I recruited 10 health professionals. This included 5 physios, 2 occupational therapists, 2 nurses, and 1 physiotherapy technician who'd all worked in cancer for at least 2 years. These individuals undertook semi-structured interviews via the telephone, and they were analysed thematically. I then recruited, subsequently, 7 patients with lung cancer and weight loss, and they were invited to ask a carer to participate in the interviews to accompany them, and we also had 7 carers. These semi-structured interviews were undertaken in person and were analysed thematically. In order to integrate the findings from the health professionals and the patients and carers, I used the COMBI behavioural change wheel. This is a model which is now being used quite extensively in behaviour change interventions. It recognises that behaviour is part of some interacting systems which include capability, opportunity and motivation, and interventions need to change one or more of these components in order to create behaviour change. So there are 3 central domains, if you like, and surrounding that, I don't know how well you can see, but in the red circle there are 9 intervention functions that suggest how an intervention might change behaviour. So the active intervention, you might say, and they've been linked to a taxonomy of behaviour change techniques. So these include education, persuasion, incentivisation, coercion, training, enablement, modelling, environmental restructuring and restrictions. So these were used to try and integrate the findings from patients and carers. So I used the COMBI as a framework to group my themes and codes from the patients and health professionals. So I grouped them according to capability, opportunity and motivation. And I also added an extra domain, if you like, of activities, because I wanted to find out what kind of activities were suitable and appropriate for patients based on what the health professionals and what the patients and carers said. So my results are shown with a couple of quotes just as examples of what the individuals said. So talking about activities, generally the feeling was that physical activities for such patients with lung cancer and weight loss should be functional. So things such as sit to stand, stairs, even breaking these down into components to allow people to practice were suitable for patients. These physical activities need to be individualised. So that might be based on assessment and should certainly allow some choice and flexibility for patients to fit the activities around their daily plan, their symptoms, and any appointments that they can do. So as we can see from Zara, who is a physiotherapist, she suggested a range of physical activities and also included that getting the family involved could also be useful. One of the patients, Jack, said he disliked being told what to do, so he likes to go at his own pace, and that's where individualisation, flexibility and choice is important. Generally speaking, it was thought that patients would need to start with light intensity and short duration, so that might be from 5 minutes, and might be doing these functional activities for perhaps 5 repetitions, really being guided by some of the symptoms and their levels of fatigue. So turning to the domains of the COM-B, so capability can be divided into psychological and physical capability. So it was felt that psychological capability required knowledge, and that attitude was also important to allow patients to actually undertake physical activity. So giving patients the skills, giving them, explaining how, what and why they need to do activity was important, and actually trying to understand their attitude, perhaps their past experiences with physical activity and any concerns they had would be really important and would affect how capable they are to undertake activity. Physical things that would affect activities that they would do would include symptoms. These are things such as breathlessness, fatigue, as well as risk of undertaking activity at home and creating a suitable environment to allow them to be active. That might be with a safe environment without carpet, it might be having somebody there as well. Opportunities for physical activity included physical and social components, physical being creating a suitable environment, equipment and technology use. So things as suggested by Rian was to use equipment to assist people to be active. That might be a perching stool, it might be a chair to give people a rest while they're being active. Carl suggested he would place his Wii Fit upstairs to encourage him to be active. Social opportunities with support from family and health professionals to provide guidance and to support and reinforce people to be active, which fits very much with automatic motivation. Automatic motivation could be affected by fear of symptoms such as breathlessness, has been identified in other quotes from the carers. And reflective motivation is about perceived benefit and goal setting, as identified by Sarah, the physiotherapist, to help them identify realistic and important goals to help them be active. And patients felt that, one of them patients felt if he could be active, he would be, because it would be beneficial for his health. So to conclude, there's quite a bit of synergy or overlap in the views of healthcare professionals and patients in the types and the ways of promoting physical activity in patients with lung cancer and weight loss. So using the behaviour change wheel, intervention functions across all of the domains of the capability, opportunity and motivation domains were identified. Therefore, principles to promote home-based physical activity include functional activity, which should be flexible, graded tasks, information and education on why, how, when and where to be active, management of disease and time to prioritise or to fit in activities. That fits in with creating plans and goals, which can include monitoring as a prompt, as well as other prompts to repeat and continue behaviour, such as rewards, as well as social support. The overlap emphasises the importance of including patients and professionals in the development of activity interventions, and this will inform future physical activity interventions in the future. Thanks.